Good morning. Good morning to everyone who has joined us for today's summit. Thank you so much. This is our third annual summit that put on by the Covering Kids and Families organization, and we're so happy that you're almost over 300 of you have joined us today. We are really excited about today's topic and most excited about the folks that are going to be speaking to you. So my name is Susan Jo Thomas, and I get the great pleasure, and it's my day job to get to introduce the panels today. First and foremost, though, I want to make sure that I say thank you to the people who have made this all possible. So thank you to our keynote speaker for doing this work for us and helping us to gather this information, stretch ourselves, and learn more about what we need to have in Indiana. Thank you. The panelists, thank you for joining us and for sharing your research, but also your lived experiences. You are awesome women, awesome Hoosier women that we appreciate very, very much, and thank you. To the CKF staff, both that you will see on the screen and those who are behind the screens that you don't see. I know how hard it is to control me and to control these processes, and I really appreciate all your work behind this. Thank you to my alma mater, the IU School of Social Work. Thank you so much for allowing us to offer continuing education units for this session. I really appreciate the belief in us that we're doing the right thing. Most of all, though, I want to thank you attendees. Thank you all for making it a 2-hour commitment to educate yourself, to get learnings that you will be able to spread around the whole state of Indiana, stretching yourself outside of your comfort zone perhaps, and learning about the barriers that our immigrant neighbors face, especially in terms of healthcare and healthcare coverage. So one of the cool things about my job is that I get to have the last vote on who the keynote speaker is. And I have been stalking and watching the research and work of our keynote today for a while. And there's so many things that are great and cool about her, but one of them I'm going to share right now is that she's a Jeopardy champion. And so I think as one of those people who make sure that they're home in time to watch Jeopardy or knows how to record it, I always make sure that we get to see who's on Jeopardy, and to have someone that was a champion on our speakers bureau is just amazing. So I in that theme, in the theme of the Jeopardy championship, I would like to say the category is Brilliant Women Speaking Today at the CKF Policy Summit. And the answer is Bioethics and Humanities professor whose research focuses on access to healthcare for non-citizens, including undocumented immigrants and refugees. I'm pushing my clicker, and the answer is Dr. Rachel Fabi. Welcome, Dr. Fabi. Thank you.
Hi, Susan Jo. Thank you so much for that kind introduction, and thank you to Covering Kids and Families for the invitation to speak to you all today. I'm just going to share my screen so you can see my slides. So I am speaking to you today about reducing barriers to immigrant health, and my talk is titled Immigrants, Injustice, and Invisible Walls. As Susan Jo mentioned, I'm an assistant professor of bioethics and humanities at SUNY Upstate Medical University, and I do a lot of research around immigrant access to healthcare, and specifically policies that affect immigrant access to healthcare. And I'm going to open with a quote from a philosopher that I love. This is from Joseph Karen's book, The Ethics of Immigration, and he's talking about the reasons why immigrants belong in our communities and why we have obligations to them. Professor Cairns writes, 10 years is a long time in a human life. In 10 years, connections grow to spouses and partners, sons and daughters, friends and neighbors and fellow workers, people we love and people we hate. Experiences accumulate, birthdays, embraces, tones of voice and senses of humor, public parks and corner stores, the shape of the streets and the way the sun shines through the leaves, the smell of flowers and the sounds of local accents, the look of the stars and the taste of the air, all that gives life its purpose and texture. We sink deep roots over 10 years, and these roots matter even if we were not authorized to plant ourselves in the first place. And in his book, The Ethics of Immigration, Joseph Cairns sort of builds an argument on why immigrants deserve access to some of the same public services that citizens have access to in the United States. And I'm going to be returning to this idea of roots and obligations to people who live in our communities and with whom we are deeply tied throughout this talk. So as I mentioned in my work, I spend a lot of time thinking about the reasons why we provide or don't provide access to public goods to immigrants. And so in this talk, I'm going to be talking about two categories of reasons. The first are moral reasons, which are reasons that appeal to ethical principles or ideas of right or wrong. So some examples might be things like respect for autonomy or justice, as I mentioned in the title of my talk. And then prudential reasons, which could also be called practical reasons, are reasons that appeal to the interests of citizens or legal residents. So not necessarily moral reasons, but more like economic or public health reasons, why we might think that immigrants should have access to the same goods and services as US citizens. So today I'm going to do a brief overview of a number of policies that affect immigrant access to healthcare. And then I'm going to present 3 different case studies in immigrant access to healthcare that is affected in some way by a policy that I think is unjust. And then I will conclude with some concrete actions that you as audience members can take to try to change some of these policies if you agree with me. So the title of my talk involved invisible walls. This is sort of an image displaying some of the bricks that build up these invisible walls, these barriers to immigrant healthcare. On the bottom, we have federal policies and federal actions that can prevent immigrants from accessing healthcare. And towards that second row, we've got things that are more like health center policies and characteristics of clinicians who interact with patients. And at the top, you have sort of individual characteristics of immigrants and community level characteristics that could affect their access to healthcare. And so I'm only going to talk about a few of these today, but I wanted to illustrate for you all that the barriers to healthcare are many for immigrants in this country, and some of them can be addressed on the policy level. So talking about policies that affect immigrant access to healthcare, I'm going to start back in the 80s with the Emergency Medical Treatment and Active Labor Act, which was passed in 1986. Shortened to EMTALA, this policy requires that all hospitals or health centers that receive public funding for Medicare, it requires that they stabilize patients who present to their emergency room before discharging them. So they can't turn someone away who presents in an emergency condition or in active labor, so giving birth. It does not require them to provide outpatient treatment, and it doesn't require that treatment be fully covered. You have to meet certain qualifying conditions to have your treatment under EMTALA paid for, but it does require that you get treatment. The next relevant policy is the Personal Responsibility and Work Opportunity Reconciliation Act of 1996. That's a mouthful, so I'm just going to call it welfare reform, which is what they called it in the 90s. And under this policy, legal residents who have been in the country for less than 5 years are not allowed to access federally funded healthcare. So programs like Medicare and Medicaid are off limits to legal residents under 5 years, or that's called the 5-year bar. And this bar on legal residents was continued through the Affordable Care Act in 2010, which also continued exclusions on other immigrants. So undocumented immigrants are not eligible for federal care. There are exceptions for humanitarian migrants, so refugees and people who have been granted asylum, but asylum seekers who have not yet been granted asylum are also excluded. And under the Affordable Care Act, undocumented immigrants also can't participate in state exchanges and are ineligible for federal subsidies that make those exchange plans affordable. And then just recently, the Trump administration made some major changes to what's called the public charge rule, which although these changes have been reversed by the Biden administration, have caused a lot of confusion among legally residing and undocumented immigrants regarding what programs they're eligible for and what would happen if they used them. So essentially what the public charge rule that was proposed by the Trump administration would have done would be make it so that any immigrants who are legally residing who used Medicare, Medicaid, SNAP benefits, so food stamps, it would make it harder for them to get a green card. And so this caused a chilling effect where a number of legally residing and undocumented immigrants withdrew their children, withdrew themselves from publicly funded healthcare out of fear that it would have negative consequences for their immigration status. And so this is a very busy chart, but bear with me. It sort of illustrates the status of a bunch of different groups of immigrants for various federal healthcare programs. So on the far left, we have green card holders broken down into children, pregnant people, and non-pregnant adults. Green card holders can access the Affordable Care Act marketplaces and are eligible for most subsidies. But as I mentioned, that 5-year bar is in place even for green card holders for Medicaid or CHIP during the first 5 years, although states have the option of providing Medicaid and CHIP to pregnant people and children during those 5 years. The next column are refugees, asylees, and humanitarian immigrants. So these are people, again, who have been granted asylum or have been officially deemed refugees by the United Nations. Resettled refugees, asylees, and humanitarian immigrants are eligible for all 3 of these programs, but experience other barriers to care that I'm going to talk about later. For others who are lawfully present, so these are people who have other visa types, not necessarily green cards, not humanitarian migrants, but who are legally present. They can also participate in the ACA exchanges, but have sort of the same complications with regard to Medicaid and CHIP. And then on the far right, undocumented immigrants are ineligible for all of these programs in most states. So the Affordable Care Act, as I mentioned, is off limits to undocumented immigrants. Medicaid and CHIP are also off limits, although they, because of EMTALA, can receive emergency medical services when needed, not necessarily funded. And pregnant people, states do have the option to fund undocumented pregnant immigrants. And that's one of the cases I'll be talking about today. And so returning for a moment to the reasons piece, the reasons why we should provide healthcare to immigrants in this country. One work, in addition to Joseph Cairns, is that I return to a lot, is a book by Patricia Illingworth and Wendy Parmit called The Health of Newcomers. And in this book, they make 2 types of arguments, one that is prudential, practical, appealing to the interests of other residents, and one that is moral. So the practical argument that they make is that health is a global public good because the health of immigrants affects the health of natives. They write that if health is impacted by social determinants, social capital, and norms, and we live side by side with newcomers, which is what they call immigrants, we cannot easily remain unaffected by their health. And so this argument is, if immigrants are healthy, it is easier for citizens to be healthy and vice versa, because health is a public good. It is something that is shared, it is non-excludable, and it is non-rivalrous. The moral argument that they make appeals to a principle of solidarity, which they define as a collective commitment to carry costs to assist others. And they argue that obligations of solidarity arise when people share goals and experiences. And specifically, they talk a lot about shared experiences in healthcare, because a number of people who work in our healthcare system are themselves immigrants. Home healthcare workers, nurses, doctors, many of them are immigrants, and they're deeply tied to our health system. And so because we share our goals and experiences with regard to health with many immigrants in this country, that generates an obligation of solidarity to carry costs for each other, which is another way of saying to use public funding to provide access to healthcare. And again, this also ties back to their prudential argument about interdependency regarding health. Again, we share goals and we share experiences in this space, and that generates duties of solidarity. So I'll be returning to these arguments as well as I work through my cases with you. My slides are not advancing. there we go, went too far. So the first case that I'm talking about today is about pregnancy care for immigrants. In this image is my colleague Saul Rivas, who is an OBGYN in the Rio Grande Valley. This image was taken from a New York Times article about access to prenatal care for undocumented immigrants. So the reason this is interesting, among many reasons why this is interesting, is that under the 14th Amendment to the US Constitution, all persons born or naturalized in the United States and subject to the jurisdiction thereof are citizens of the United States and of the state wherein they reside. Essentially, it doesn't matter if your parents are immigrants, if they're undocumented, if they're documented. If you are born on US soil, you are a citizen. And so access to prenatal care for pregnant people who are immigrants could be really important for a number of reasons. This is the New York Times article I mentioned. This came out last year. Undocumented and pregnant, why women are afraid to get prenatal care. Undocumented women are risking their health by postponing prenatal care and giving birth at home in response to the Trump administration's immigration enforcement policies. So layered on top of policies that affect immigrant health just on the basis of eligibility, we also have immigration policies that might scare people into not even seeking care, even if they're eligible for it. And because of this sort of web of policies, undocumented women are more likely than citizens to experience inadequate prenatal care, birth complications, childbirth-related hospitalizations, and they're more likely than documented, so legally residing immigrants, to experience low birth weight. Recognizing this, the American College of Obstetricians and Gynecologists issued a committee opinion saying that undocumented immigrants should have access to the same level of prenatal care as citizens. And recognizing this also, there are two options, policy options, that states have to provide this care. So the first option is called the unborn child option, which is an option through the Children's Health Insurance Program. This policy came into being in 2002 under President George W. Bush as sort of a plank of compassionate conservatism. Essentially, this policy allows the state to define a CHIP-eligible child as anyone from conception to age 19 instead of birth to age 19, essentially making the fetus a potential beneficiary of CHIP funds. And for states that use this option, they can receive federal matching funds at the same rate as other CHIP programs. But there are restrictions on what services this can cover. CHIP only will cover care that directly affects the fetus. Now, how states parse out what care only affects the fetus and doesn't affect the mother is sort of an interesting question that I have explored elsewhere. And it differs from state to state, but sometimes this might mean that while routine prenatal care is covered, morning sickness medication might not be. And then the other option that states have is to use state-only funds. So under welfare reform, states were told that they couldn't use federal funds to cover unqualified immigrants, including the undocumented. But it left it available to the states that if they wanted to use their own money, not federal money, to cover this population, they could. And so a few states do this, including New York, where I am currently sitting, and states that use this option generally just eliminate the immigration status eligibility requirement for pregnant people. And so what this means is that if you are pregnant and in the state of New York, you can enroll in a Medicaid lookalike. So it's not actually Medicaid because you can't use federal funds, but all of the services are the same. So it's not federally funded, it is only states, but there are no federal restrictions on the scope of benefits, and it essentially functions just like regular Medicaid. So in terms of which states use which policies, you can see the breakdown here. The states in blue use the CHIP unborn child option. The states in green, essentially just New York and New Jersey, but also DC, will use their own funds to cover this population. And as you can see, Indiana in gray doesn't use either of these policies. And so in states that don't use either of these policies, many undocumented immigrants can seek prenatal care at federally qualified health centers where they pay out of pocket on a sliding fee scale, which for some people is affordable, but for many it is not, and that presents a barrier to care. In addition to the unborn child option and the state-funded option for undocumented women, CHIP and Medicaid offer states the option of covering lawfully residing, so people on valid visas, the option of covering pregnant women during their pregnancy, during that first 5 years, when there's otherwise a 5-year bar. And so the states that do this, that use CHIP funds or Medicaid funds to cover pregnant women during the first 5 years that they're here, are in dark blue. Again, Indiana in light blue does not use this option. And similarly, under the same policy, states could cover lawfully residing children during that 5-year bar. Again, Indiana is not one of the states that chooses to do so. And so for my dissertation work a few years ago, I interviewed providers in different states that treat undocumented pregnant patients. And one nurse midwife in Maryland, which doesn't use either of those policy options, talked to me about how she felt like her hands were tied when it came to providing care for her pregnant patients who needed specialty care that they could not offer in her federally qualified health center. She said, I feel like my hands have been tied. There's nothing else I can do. And that's been hard. And this was a theme I heard again and again from providers who could not meet their standard of care, who couldn't refer their patients for necessary treatment because of policy restrictions on who is eligible for healthcare. So to talk back about those moral reasons and practical reasons for a moment, in terms of moral reasons why undocumented children and pregnant people should have access to healthcare, I return again to Karen's and his argument about these community ties mattering and these deep roots that we set over time mattering. For both pregnant people and their children, there is an expectation that they will receive their social formation for children and babies born in a state. They'll receive their social formation in the state where they're born. And that membership in the state, both for the children, for babies born in that state, and for their mothers, that matters morally. And then going back to the solidarity argument from Illingworth and Parmit, again, we have this idea of interdependence in health. So providing prenatal care to ensure a healthy pregnancy is one way of trying to ensure that you have a healthy birth and a healthy child who will grow up to be a healthy adult. And in the event that we don't do that, that could impact the health of everyone around that child. So Joseph Cairns, talking about providing access to healthcare for children and pregnant people, writes, this is the right thing to do from a purely moral perspective, but it's easier to persuade people to go along with the idea because it is so clearly in everyone's interest not to have children growing up in our society with medical conditions that might pose a risk to others. So let's talk about some of those practical reasons, because this is a case where the right thing to do and the practical thing to do are actually the same thing. So the impact of providing prenatal care to undocumented people, there's been a good amount of literature that shows that expanding access to care improves prenatal care utilization. I have 2 screenshots on the bottom here of papers from that literature. The one on the bottom right I was involved with. And in that work, we showed that using the unborn child option or a state-funded option ensures that pregnant people access prenatal care at a higher rate. Our study didn't detect any changes for infant health or for maternal health, but the paper on the left and other papers that have followed did in fact show that access to prenatal care and that increased utilization did result in improved health outcomes for women and children. And so we still need evidence on the long-term effects of these policies on child health and development. But in terms of short-term evidence, you can see here that red line represents the number of undocumented people on emergency Medicaid. So that their births were covered by emergency Medicaid, which means we're pretty sure they're undocumented. The incredibly steep drop after Oregon passed the unborn child option in the number of women who received inadequate prenatal care. There is just a clear association that can't be denied between this policy and better access to care. There's also some research that shows from like just a purely practical perspective that for every $1 in prenatal care costs for this population, we save $3 in postnatal and long-term expenses. So that's sort of in a more general sense. But again, returning to Oregon, those same authors showed that providing prenatal care for the 84,000 women annually who are undocumented and uninsured providing prenatal care to 84,000 women prevents 117 infant deaths and 34 cases of cerebral palsy. They also showed that prenatal care only costs $380 more per woman than covering delivery only, which is what we're doing under emergency Medicaid because of EMTALA. And so for every additional 865 women receiving prenatal care, 1 infant death is averted, which is the part where as an ethicist, I get a little bit squeamish, but if you agree with the economic analysis of putting a dollar value on a year of life, it's an average cost of $328,700, which all cost effectiveness analyses show is a better use of money than accepting those infant deaths. So normally when I give this talk, I'm from Pittsburgh, Pennsylvania originally, so I would show a picture of the point in Pittsburgh where the Allegheny River and the Monongahela River come together to form the Ohio River, to illustrate that sometimes the right thing to do and the practical thing to do are the same thing, and that's what you should do. In the interest of, in Indiana and giving this talk for CKF Indiana, I went and found a river confluence in Indiana. This is the Wabash River and the Ohio coming together to illustrate that in this case, the right thing and the practical thing are the same thing. So turning to my second case, I'm going to talk about access to Medicaid for undocumented immigrants, and specifically undocumented immigrants with end-stage kidney disease. So this is the story of Hilda, who's pictured here in the middle, and her 2 sons. Hilda was a patient of my good friend and colleague Lily Cervantes in the state of Colorado. Hilda was an undocumented immigrant who had come from Mexico as a child and had grown up in poverty in Colorado. And Hilda had end-stage kidney disease. Because she was an undocumented immigrant, she was ineligible for Medicaid. And so every time that she went into kidney failure, she was able to receive emergency dialysis in a hospital in the emergency department, but she was unable to receive standard routine maintenance dialysis. And so Hilda's sons would have to call 911 every time she collapsed so that she could be brought to an emergency department to receive dialysis. Hilda was a patient of my friend Lily Cervantes, and her story and her experience with Hilda motivated a lot of advocacy work that Lily did to get this policy changed. I'm going to talk a little bit about that today. So first, just this sort of story about immigrants forced to wait until the brink of death to get kidney care received a fair amount of coverage in the news media. This is from the Denver Post, and also we have from CNN in a story from Dr. Sanjay Gupta, undocumented immigrants on dialysis forced to cheat death every week to wait until they were in crisis in order to receive emergency dialysis. This is an image from a graphic novel about the experience of undocumented immigrants with end-stage kidney disease. It says, without regular dialysis, undocumented patients with kidney failure face death almost weekly. Waiting until shortness of breath, vomiting, or fluid buildup forces them to the hospital where they can receive emergency dialysis. So Dr. Cervantes, who was a friend of Hilda and who witnessed her death, after her death, organized her entire career around researching emergency dialysis for undocumented immigrants and advocating for changes. And as part of that research, she interviewed other patients who had that experience, who had to wait until they were on the brink of death to receive dialysis. So this is from the paper cited in the bottom right. I've had people pushing on me right here, my chest. I think it's happened 3 or 4 times, but I don't remember much except that my chest hurt a lot afterwards and my family thought I was dead. Dr. Cervantes also interviewed some of her colleagues and other internal medicine doctors and providers who were involved in providing emergency-only dialysis to undocumented immigrants. And so in speaking with them, it became really clear that this policy was causing them a great deal of distress, as it had for her. One provider told her, you see patients that are awake and alert and talking, and then they come in a week later and they're basically in cardiac arrest and they die. This has been a really tough thing to experience, people you know by name. So returning to these reasons why standard dialysis should be available for undocumented adults. As with the pregnancy arguments, community and solidarity are still pretty paramount for me, but other reasons that we might consider: preventing suffering, especially doctors, but not just doctors, have an obligation to prevent suffering. And from the interviews that Dr. Cervantes did, from Hilda's story, it's really clear that waiting until people on the verge of death to provide a necessary medical service does not meet that obligation. Similarly, we have an obligation to keep families together when possible. Hilda's sons lost their mother, and other children have lost their parents because they were not able to access standard dialysis. And that fails our moral obligation to prevent, to keep families together. And then finally, this idea of moral distress, which is explored pretty greatly in the bioethics literature. Moral distress is a phenomenon that providers experience when they are unable to live up to their personal or professional obligations because of some obstacle that they cannot overcome. In this case, policy requirements about who is or is not eligible for dialysis. But turning to some practical reasons, in case the moral ones aren't convincing, you can see here the difference in cumulative mortality for patients who are treated with emergency dialysis versus standard dialysis. For patients who must rely on emergency dialysis are very likely, almost 75% more likely to die within 5 years than patients who have end-stage kidney disease who receive maintenance routine dialysis. I'm not going to make you read these tiny numbers, but I've distilled out some of the points here. Dr. Cervantes' research has shown that when patients receive standard dialysis as opposed to emergency, they experience 5 fewer ED visits per month. They experience 1.6 fewer hospital days per 6 months. And there are cumulative about $6,000 per person savings per month when maintenance dialysis is provided instead of emergency. So as with prenatal care, I think it's really clear that the right thing to do, providing maintenance dialysis, and the practical thing to do are the same thing. And so states that don't have policies to protect undocumented immigrants from meeting the same fate as Hilda are failing in their obligations. And so as a result of Dr. Cervantes' advocacy and the advocacy of many of her colleagues and her patients and the undocumented community she served, Colorado changed its rule so that undocumented people can get regular dialysis. And as you can see in this headline from Colorado Public Radio, it saved lives and dollars. It is morally correct and it is practically correct. In terms of how they did this, so under EMTALA, under emergency, the requirement that you treat people who present with an emergency medical condition, the federal government leaves to states the right to define what an emergency medical condition is in their state. And so by defining end-stage kidney disease as an emergency medical condition, without reference to how high your numbers are, what kind of crisis you're in, just having end-stage kidney disease is an emergency condition now in Colorado. Because it's covered under that definition, people who have end-stage kidney disease, regardless of their immigration status, are able to receive maintenance dialysis. And again, I've got a map for you. You can see which states do this. The states in green use Medicaid through that definition change to provide reimbursement for standard outpatient dialysis to this population. In orange, Medicaid does not provide reimbursement for standard outpatient dialysis, but there are funds that cover standard outpatient dialysis outside of the Medicaid system. And states in red don't have either. And as with the previous two maps, Indiana in red doesn't do either of these things. So turning to my last case, I'm going to talk a little bit about refugees. And unlike the other two groups I talked about, I'm not going to talk about a specific policy barrier to care, but rather to other barriers that refugees face when seeking care. And specifically, I'm going to talk about a research project I've been involved with here in Syracuse around refugees and COVID-19, and specifically access to vaccination for this population. So in this image, you can see a number of refugees represented from various communities here in Syracuse, from the various countries that they've resettled from. who all got together for World Refugee Day last year, essentially arguing that they needed better support from the city. That man in the middle is giving a speech about the power and the resilience of this community, but also their needs and how the city could do a better job of meeting them. And this was happening in the context of COVID-19. Now, of course, COVID-19 has impacted everyone around the world. But I want to talk a little bit about specifically how it has impacted resettled and accepted refugees. These are findings from a paper by Brickhill, Atkinson, and Hawk. So not my own work, but I, in my work, have observed all of these things affecting the refugee population here in Syracuse. So the first way in which COVID really hurt the resettled immigrant community and the resettled refugee and accepted refugee community here in Syracuse and around the world involved the suspension of resettlement and related services. So because of COVID, many refugees who had been accepted or for admittance to the United States were not able to be moved right away. So they were exposed to prolonged persecution in either their country of origin or in their second country where they were awaiting resettlement, and experienced delayed reunification with family members. They also, because of these lags that were created by COVID, experienced the expiration of security and health checks, which can take up to 3 years to acquire in the first place, setting back their resettlement timeline by at least 3 years. And for refugees who did make it to the United States, they received sort of a modified, scaled down resettlement assistance once they arrived, because resettlement agencies were not able to do anything in person during the early days of COVID-19. As with much of the country, refugees experienced significant economic hardship as a result of COVID-19, including disproportionate job loss, difficulty accessing relief, either because of language issues where refugees were just not able to complete the forms needed to apply for relief, or because of issues of understanding, not knowing that they were eligible for relief from COVID-19 hardship. And this resulted in reduced support for overseas family members, which was also sort of emotionally challenging for many refugees here in Syracuse. Another impact of COVID had to do just with the disease. So refugees tend to live in overcrowded conditions and to experience higher rates of comorbidities compared to citizens and other non-refugee immigrants. And they also are more likely to work in high-risk occupations. So many who did not lose their jobs were working in essential roles where they were exposed to higher rates of COVID-19. And additionally, many delayed care and were not on the front lines of receiving public health assistance as well. Mental illness exacerbations were particularly hard on this community as well, partially because there's just already a higher need among many resettled refugees because of a history of trauma prior to resettlement. And for many refugees, the social distancing and isolation requirements around COVID brought up memories of forced isolation and hiding in their home country or in their second country prior to resettlement. And as with other services, there were modified and reduced access to mental health services for many refugees because they didn't have access to the technology needed to engage in, for instance, Zoom therapy. Communication challenges, so again, barriers to virtual communication, but also a need for linguistically appropriate information, which was not always available. Information about where testing was being held, where vaccines were available, that wasn't always translated into every language needed for every refugee group. And then finally, the impact on children from school closings and from the loss of daily structure. I'm working on another project that I'm not going to get into today, but about the effect on the mental health of children. And it's been really painful to interview families who experience this. So turning again to moral reasons why refugees should have better access to health and all of the things necessary, the determinants of health. Solidarity and community, I'm not going to rehash that, but we have obligations to carry costs for refugees because they're our neighbors, our colleagues, our friends, because some of us are immigrants and refugees ourselves. But in addition to these obligations that I've discussed that were relevant for other immigrant groups, I want to talk about refugees specifically and a duty to repair. So right now we're experiencing an influx of refugees from Afghanistan many caused to flee because of the harms that the United States has done in Afghanistan over the last 20 to 30 years. And when we are responsible for the harm to someone else, that generates additional duties to repair. And then finally, refugees experience an inability to return home. In fact, by definition, a refugee is someone who is either unwilling or unable to return home because of a fear of persecution due to race or gender or sexuality or any number of protected categories. And so because they can't return home, they're especially vulnerable to the state in which they're currently living. And in our case, that's the US. So we have extra obligations because of this enhanced vulnerability. So in order to address some of these needs in my community, I'm just going to talk a little bit about the project that I've been involved with. Working in partnership with Catholic Charities, which is one of the main resettlement organizations here in Syracuse, we've worked to distribute necessary products like cleaning supplies to refugees, gloves, masks, etc. But more than that, we've established a testing clinic that started in June of 2020. And you can see on the right a number of one Upstate physician, so I'm from SUNY Upstate, this is my colleague Andy Shaw, and then a bunch of refugee health navigators who are themselves refugees and whose job it is to help connect refugees with needed health services. So starting in the summer of 2020, we began providing weekly testing at the resettlement agency so that refugees were able to access testing when they were otherwise unable to get to testing sites. And out of this project, we developed a community-based participatory research project where community stakeholders, many of them refugee community leaders, and those refugee health navigators that I mentioned earlier, came to the research team and said, we're concerned that people are not getting vaccinated. And we developed with them a research protocol to try to investigate why people weren't getting vaccinated and how we could help. And so working with health navigators, refugee families, the staff of the resettlement organization and other resettlement agencies here in Syracuse, we developed this research protocol, which involved interviewing community leaders and refugee health navigators about these challenges. And so a few things that came out of this research, first were the hesitancy related barriers to COVID vaccination. So refugees were spreading rumors about side effects that they were reading on social media regarding, the side effects of the vaccine. One community leader told me the bad news goes very fast, that the vaccine will cause death, or it will cause this symptom, or it'll make you sick, or it won't cure the virus. And those are the things I hear all the time in the community, and that's challenging for us. But more than hesitancy barriers, I heard about access barriers, things that are modifiable by the city, by the county, by the state, to make access to vaccination easier for refugees. One such barrier was communication. So again, many refugees don't have access to high-speed internet or the technology needed to do virtual health visits. But on top of that, this community leader told me that even using the phone was challenging for many refugees. He said, imagine somebody from our community wants the vaccine now. There's no way to spend 2 or 3 hours online. There's no ability, no concept about applying for the vaccine online and being kicked out and going back and kicked out and going back and trying the 800 number and waiting. That concept doesn't exist. Similarly, we had issues with transportation barriers. So here in Syracuse, the COVID vaccination site run by the state was outside of the city at the New York State Fairgrounds. And so many refugees that I spoke with said it's very hard for us because there's no resources and funding for people to travel to the fairgrounds or to any other site. So if you had a vaccine clinic on the north side where folks live, they could drive by or they could get to the refugee resettlement agency easily. But trying to get out of the city was impossible for many refugees. And so they proposed some solutions. Having a vaccine clinic in the community a few minutes walk away. It would be an easy way to convince people, and they can reach the building physically and encourage others to do the same. They also suggested educational sessions. One community leader said you can make a session with many families and talk in person. And when you have this session, I suggest you have a doctor from the hospital. I need a doctor in front of me. I need to ask him and I need him to answer me because I have many, many questions. And so we listened to our community partners. And so we did a number of events. We're still doing events. We're having informational sessions. On the left, you can see a panel of Arabic-speaking residents from our hospital who worked with a local mosque to do a COVID vaccine Q&A. And on the right, the Syracuse Korean Baptist Church, which serves Burmese refugees. We had an informational session there, followed by a clinic in partnership with a local pharmacy that resulted in 60 people getting vaccinated. And so this is just sort of a case study in barriers to health that refugees can experience, obviously exacerbated by the public health emergency of COVID. But what's the solution? Governments could improve and extend resettlement services. Many refugees lose access to resettlement services within the first year of relocating to the United States. And not having that expanded access means that they lose casework, they lose connections to resources that they need to continue to adapt to life in the United States. And with improved and extended resettlement services, maybe we wouldn't see some of these barriers cropping up. Additionally, governments have an obligation to improve public understanding and attitudes towards refugees. If the public were more welcoming, people would be more likely to volunteer, to donate, and to help make this community stronger. Related to that first point, we should be extending refugee medical assistance and refugee cash assistance beyond the first 8 months. It's just not enough time to get your feet under you in a new country where you don't speak the language and establish yourself in your community. 8 months is just not long enough. And then finally, again, as COVID made really clear, governments should be anticipating and addressing the language and cultural barriers that refugees experience when seeking care. So this could mean working with communities to develop accessible materials and accessible methods of accessing care. So again, the right thing to do and the practical thing to do for refugee health is the same thing, and that is to expand the support that we give refugees when they arrive in the United States. So turning now to some concrete actions that you can take to break down these walls, I considered using a picture of Miley Cyrus here, but she's not wearing enough clothes for a public talk. So instead, I just grabbed a regular wrecking ball to try to tear down some of these invisible walls. So the first concrete action that you can take, especially on this prenatal care issue, is to contact your state Medicaid office or your state legislator to ask them to adopt either the unborn child option or a state-funded prenatal option. So you can see here on the left, the Office of Medicaid Policy and Planning for the state of Indiana. I did a little bit of digging. You can submit a policy consideration form asking them to make this change, and then they'll research it and consider your request. In the state of Indiana, you actually don't need legislative action to make this change. It can be done through a state plan amendment, which doesn't require legislative approval. The state of Nebraska, you can see on the right, did use a legislative bill to make this change. This was a bill that was passed in 2011, which essentially adopted the unborn child option for the state, but it can be done without legislative action. Also, along the same lines, on the federal level, you can support the Lift the Bar Act, which would eliminate that 5-year bar for legally residing immigrants. And so if you want more information about this bill and about actions that you can take to support changing it, you can go to protectingimmigrantfamilies.org/take-action. The link is there on the bottom. On this dialysis question, again, this is something that your Medicaid office can do without any legislative action. All they have to do is define end-stage kidney disease as an emergency condition. And so this is another thing that you could request through the State Office of Medicaid Policy and Planning. The link is at the bottom. And I'll try to put that in the chat or ask someone to put that in the chat later. Finally, on refugee health, some actions on the policy front, contacting representatives to advocate for expanded or improved refugee services. So expanded access to refugee medical assistance, expanded literacy and health literacy support, and especially expanded mental health support for refugees. On the community level, if you're not interested in calling your representative, just be welcoming to new refugees, especially those who are now arriving from Afghanistan. And this could involve donating funds or household goods. When resettled refugees arrive here, they're often provided an apartment that is lightly furnished, and those furnishings often come from donations. And similarly, you can volunteer. Resettlement agencies are always looking for people who can help with English language and citizenship exam tutoring, mentoring to help newly arrived refugees find jobs, or people to help with tech support and digital literacy, which, as we've seen, is a major barrier to health. And then my last point is at the institutional level. So this is across all immigrant groups. My colleague, Dr. Altaf Sadi, put together a toolkit, which you can access at doctorsforimmigrants.com, which has a number of steps, videos, resources for institutions looking to adopt immigrant-friendly policies that make it easier and safer for immigrants to access care. In the interest of time, I didn't get into this today, but I wanted to just plug the website and these resources because it's really incredible work, and it makes it super easy for institutions to adopt policies that make immigrants safer. So in conclusion, I'm going to return to these two images that I've shown again and again today. When it comes to immigrant healthcare, I think it's really clear that the right thing to do and the practical thing to do are the same, and that is to expand access. Immigrants are members of our communities. Some of us are immigrants. Some of our parents or our grandparents are immigrants. And we've all set deep roots in our communities. And as Karen says, these roots matter even if we were not authorized to plan ourselves in the first place. So I'm really grateful to everyone who came out today to hear and learn more about immigrant health. Clearly, this is the audience who can advocate for change to improve access. And so I'm really excited to hand it back over to Mark and to hear from our incredible panel today. And thank you again for your time and attention.
Well, thank you so much, Dr. Fabi. What a great start. And you gave so much wonderful material for us to dig into. So made the panel part of this discussion easier, at least on my end, because I think I've got about 20 pages of notes to start us off on. So wonderful to have that. Our panelists are going to be switching over now. So I'll wait for them to get their video up and running and get all unmuted before we get into introductions. But I do want to let all of our attendees know that we will be using the chat function to watch for any questions that you have of the panel as we're talking through. So feel free to use that. Try to stay away from the Q&A. It just doesn't work quite as well, but I'll watch both and we'll make sure we get to as many questions as we can. You know, we have a little bit over an hour and we probably have about 6 months worth of material that we could cover, but we will certainly be doing our best there. Before I forget to introduce myself, I'm Mark Fairchild. I'm the Director of Policy and Communication with Covering Kids and Families of Indiana. It's my task to make sure that we have good policy, that we're promoting good policy across the state, but also that we're communicating in ways that get people active and involved in health coverage issues, healthcare issues, other issues surrounding different populations, and also just make sure that the populations that we work with can understand how we're trying to communicate with them and provide services to them. So it's always my pleasure to be able to be a part of a panel like this where we get to hopefully get a lot more professionals involved and give you some ideas of what can be going on in the future going through. So again, it's very easy on me today because we have such great folks on the line. I'm going to give some very brief introductions of our other panelists. We're lucky to, of course, still have Dr. Fabi with us as we go further in. But we have 3 other incredible women, all that have a lot of background and a lot of personal connection to immigrant health as well. And I couldn't be more proud with the folks that have been able to pull together to aid in this presentation today. So going in no particular order, I'm happy to show that we have Gurinder Hohl with the Immigrant Welcome Center. She's the CEO of that organization. And they have the very complex role of focusing on all kinds of initiatives to promote community-wide awareness of all the great cultures and ethnicities that we have, especially in the newer immigrants that are coming into our communities. How can we be prepared for them? What services do we need to have lined up? How are we truly a welcoming community in this area? And how do we get stakeholders to understand the barriers and challenges and all their other complexities of our so many immigrant populations. Of course, currently she's got a great example of that, as we have a big part of the role being led by the Immigrant Welcome Center with the Afghan refugees that are coming through and the response related to that. So I'm sure we'll get to hear a little bit about all the different ways that we can truly welcome those types of immigrants. Next, I'll say we have Dr. Kosali Simon. She's the Associate Vice Provost for Health Sciences at Indiana University and is a health economist, which you'll get into all the good things that means. So you folks that are numbers people are certainly going to love having her with us today, but she's a great part of being able to look at that, look at the pragmatic details of what's involved in our healthcare system and how it makes not just good sense as the moral thing to do, but as the economical thing to do too, because sometimes we miss the interconnection between those pieces. She's done a lot of work recently looking at large-scale real-time data associated with COVID and some of those impacts. And most recently, Dr. Simon was elected to the National Academy of Medicine, which is a pretty awesome accomplishment. So awesome to hear that, right? And certainly not least, Dr. Sarah Stelzner, who I think I'm on probably about 30 different subcommittees with. So her involvement speaks for itself, certainly. But she's an assistant clinical professor of pediatrics with Indiana University. She's also a primary care provider at the very diverse group of the international marketplace at the Eskenazi West 38th Center, where she gets to see just dozens of different immigrant populations from all over the world. It's a great intersect of all the different things we could see on the provider side. So she's going to be sharing a lot from that and from her unique experiences there. So again, couldn't be more thrilled with the panel that we have here in front of us. What I'm going to ask you now is we're going to go into a few of our kind of warm-up questions. Don't worry, we'll have plenty of time to react to Dr. Fabi's presentation as well. Again, I'll be watching the chat, so we'll get any good questions you want to drop into the chat if you're listening as an attendee. But wanted to start with just going into a little bit of getting to know our panelists better. So you all have professional connections and personal connections and a lot of reasons why the work you do. So I want to start with, it's hopefully an easy yet complex question, is why is immigrant health such an important issue for you? And why do you choose to do service in this area? Maybe we'll start with Dr. Stelzner on that, and we'll go around the panel from there.
Finding the unmute button. So thank you for the invitation. It's an honor and a pleasure to be here with everybody. I am lucky to be a daughter and granddaughter of immigrants, so I come to this honestly. I lived in California, New Mexico growing up, and also am honored to call myself a Hoosier, having lived here for now 23 years. And just really my work with Wishart and Eskenazi over those 23 years and the really amazing transition and evolution that I got to make moving from campus out to West 38th Street, and just being able to be part of a wonderful integrated system that really tries its best to meet the needs of all of our really diverse and amazing families that we serve throughout the system, really, but especially at West 38th Street. So I'm excited to talk about our experiences.
Wonderful. Thank you, Dr. Stelzner. Let's see. Next, I'll go ahead and volunteer. If we could hear a little bit more from you, Kosali, on kind of some of your personal connection and your interest in this area.
Sure. So it's a professional topic for me as an economist who studies state and federal health policy, but it's also a personal topic because I'm an immigrant. I moved to the United States as a 17-year-old, leaving then what was a war-torn country at the time, and so have gone through the process myself and really think that there's a lot to trying to understand the experience that is involved in.
Great. And again, I'm sensing a theme here of the kind of connections that we have. Again, certainly not least, but last, Gurinder, what do you have for us by way of introduction for your connections to this issue?
Thank you, Mark. I am so honored to be in the company of such esteemed speakers. Rachel, your presentation was fabulous. I am an immigrant myself. I arrived in the States in the early 1990s as a physical therapist myself. So as a healthcare provider and now a public health professional, I have lived experiences of some of the challenges that immigrants face. And I'm really proud to say that an organization that has existed for 15 years, I am the first CEO who is a woman of color and who's an immigrant herself. So needless to say, the topics that we have discussed today, the case studies, the challenges that Rachel has talked about are all that we are seeing every day as through our natural helpers who are community navigators. That's the term that Rachel used. And also as our helpline rings from 9 to 5, the most common needs that we get are related to food, healthcare, housing, and legal services. So really interested in this conversation, sharing more insight, perhaps more examples of how linguistic access has created huge barriers for our immigrant communities here in Marion County and Central Indiana. So thank you.
Thank you. And don't worry, linguistic barriers, I think, is definitely on our list to tackle today, for sure, and massive issue that is often overlooked. Okay, so before we get into some audience-related questions, something else I'd like to give everybody the chance to do, of course, except for Dr. Fabi, she gets passed on this one. But does anybody have an initial response to her presentation or something that really stood out to you as an important issue that you see maybe regularly in your work, or you think as a state that we need to pay particular attention to? And I'll open that to the whole group if we have anybody that has an immediate response.
Yeah, I'll go first, Mark. One of the things that I'm not sure how many of our audience members realize, Dr. Stelzner, she is a daughter of immigrants. I am an immigrant myself. Dr. Simon is an immigrant herself. Immigrants look different. We have different languages that we speak. We have different cultural heritages. And just because we're immigrants doesn't mean that our needs are the same. So, that cultural responsiveness and assuring that we are understanding what our needs are is really important. And I'll give you one example. That happened during the time of COVID here. When the first time the city of Indianapolis declared the curfew in the month of March, April, it was only declared in English, no other language. Imagine that. I'm very fluent in English. A lot of our immigrant refugee neighbors are not. They're actually even illiterate in their native languages. So imagine when you are in a frontline job and you hear about this disease that is impacting the countries around the world, and then something has happened in your city that you're not allowed to go out. What are the implications of that on your family life, on your job, on your being able to put food on the table? I think that is something that I'd like for our audience members to reflect upon, that how important such a simple thing, the domino effect of that. And I'll yield the floor.
I can go next, perhaps. I thought what you covered, Dr. Fabi, was just fabulous. So much background information, really a lot of detail. And one of the things that stood out to me was that the policies that cover immigrants are just so complex. It's hard to understand what applies to whom in what type of situation and what are the consequences. But one thing is clear, that there are very severe consequences. So as a result of the way the policies may be broadly understood, it's impacting not just, even if the rule is, oh, this is different for undocumented versus documented status, the message that comes across is a chilling one. And so, as research has shown, policies impact further than intended audiences because of chilling impacts. And so even it has broad consequences for people's perception of access to care, which then translate into care that might be delayed. And ultimately, it is everybody's issue, right? It's not something that we can legislate away, because either we have policies that accept all comers to doors through EMTALA, or through other means. Even if we didn't, it becomes a consequence for society. So the two things being just the complexity of the message that comes across, even to unintended audiences, any connection to immigration, not understanding how will this impact others in the community, where if I bring attention to myself through my actions, maybe it'll affect somebody else who's in a more risky situation. And just understanding how does that impact care seeking in ways that affect everybody in society ultimately. I think those were, among the many points you really well articulated, the things that stood out to me.
I'll just segue on that in terms of unintended consequences and how surprising and saddened I was to see the data on prenatal care. Obviously, it's a critical service, but when I first started talking to students about cultural competence and Latino health beliefs, I remember the slide that kind of presented the immigrant paradox, where despite the fact that immigrant mothers or women were, didn't have as much access to care, might be living in poverty, language barriers, et cetera, they had overwhelmingly more positive and healthy outcomes during pregnancy for their babies. And so the slide that you showed that is showing more negative and poor outcomes was weighed heavy, because we have certainly contributed to that as a health system. And then the description of social formation from the authors that you quoted, and the work that the AAP is really driving forward, and I know other stakeholders as well, American Academy of Pediatrics, AAP, about the importance of positive childhood experiences. And so the description that you gave of that social formation and the roots and the community connections and that kind of social capital that we need to help build for families and children really struck home as well, because there's data that shows that these positive childhood experiences mitigate the toxic stress and the negative, the ACEs, the adverse childhood experiences that can have such long-lasting brain changes, health outcomes, and really consequences to all of us as well. So thank you for pointing that out.
Thank you all for your input on that one. Certainly, again, I'm going to have to reread her presentation for all the little tidbits that are in there. Certainly, it shows us there's not a shortage of issues that we need to be addressing as we go through things. And we do have some questions starting to come in through chat. Some even directed to a couple of you specifically. So get ready for those in just a second. I did want to ask just one more kind of framing question, and I think Gurinder started us on this one, and Dr. Stelzner might have something to add as well. But it's important we talk about immigrant health, and we do sometimes kind of lump populations together. It's our way of trying to problem solve, say, well, it's the immigrant population, no different than when an organization thinks they're doing Hispanic outreach because they put one of their brochures in Spanish. No, problem solved, right? And we know there's such a range within that. So we'll start with you, Dr. Stelzner, because you see such a range of folks coming in through Eskenazi. When we talk about the immigrant population, who are you seeing and what are some of their health needs? If you can summarize that in less than about 3 days worth of descriptions.
Well, I'll just maybe do a shout out to some of the work that we're doing to give you an overview. Two of our providers have really kind of piloted and expanded our ability to screen our families and patients, both for maternal depression and socio-emotional health of young children. So we use in Edinburgh and something called the SWIC. What we had to do was actually copy these screens in multiple different languages in order to really provide health equity and be able to enable everybody coming in to participate in this screening and the referrals that we might be able to provide to them. So I'm just going to read a list of the languages. Yoruba, Spanish, French Creole, Arabic, Tigrinya, Kenya, Rwanda, Amharic, Pashto, Punjabi, Swahili, and French. So within that wonderful milieu of languages comes people who are at every different sort of category of arrival. Obviously, the most recent arrivals from Afghanistan, we're definitely seeing those families to people from, all over Africa, the Middle East, and then the most, another recent arrival, and as you can imagine, really an impact of current events are Haitian families who really are settling all over Indianapolis. We're on the west side of 38th Street, but I just talked with a colleague on the east side of 38th Street at Grassy Creek, and they are seeing many Haitian families. And so, again, really, I think if you just listen to the news every day, Indianapolis is seeing the impact of world events and what's happening around the world, and really consider ourselves grateful to be able to provide hopefully what is a soft and warm landing.
Great. And Gurinder, I'm sure you have more to add.
Yeah, I do. As Dr. Stelzner noted, the languages that she pointed out are the same languages that we get requests in the most in. Last year during COVID, we started collecting really intentional data about where our helpline calls were coming from. I mentioned that we have a helpline which is available 9 to 5, Monday through Friday. We have a language line, so the staff at the Immigrant Welcome Center, including myself, are either bilingual or multilingual. I'm multilingual, but we still can't cover all the languages that Dr. Stelzner talked about. So we have made a significant investment into a live language line. So if Mark calls and he speaks Swahili, and I don't have anyone on staff who speaks Swahili, we will put Mark on hold and get a live interpreter who speaks Swahili so that we can help Mark in real time, which is a best practice and which is an intentional investment, because we believe that our immigrant neighbors have so many barriers that if we can address their need in real time while they're on the phone with us, we can help at least give them a little bit of comfort, right? So that's something that we're doing. Other things that we have also noticed are related to food insecurity. Our dear friends at Cleaners during the COVID had set up pantries throughout the city. And there were two things that were happening at these pantries, dear friends. One, that they had, just for security reasons, I don't understand why, I've never heard of looting of a pantry, but anyway, let's leave that aside. Just for security reasons, they had a National Guard outside the pantries in uniform. Can you imagine if you are an undocumented individual, the impact of seeing that? That's a barrier right there. We've just created a structural barrier right there. And then if you're able to get into that pantry, imagine you bring the box home and you see applesauce, macaroni and cheese, and items such as a very American food, mashed potatoes, etc. I wasn't born eating. I don't eat those items even now. That I've been living in the States there longer than I've lived in India. So they had food, but not food that they can eat. So we've provided consultations to gleaners about those two issues. And that has had a huge impact on addressing some of these food insecurity issues, where specific pantries on the west side of Indianapolis now, where we found that a lot of individuals who eat rice and beans use olive oil instead of vegetable, or use vegetable oil instead of olive oil, would prefer to have spices, fresh fruits and vegetables are available. Just to give you, again, these basic needs, how simple changes can make a huge impact, and how the domino effect, again, of those simple changes can be on the health and well-being of these individuals and their families.
I'd add something to this discussion about the diversity of the immigrant experience and the size of the immigrant population. So if we look at the US as a whole, we think about two categories. There's non-citizens and there's immigrants who are naturalized citizens. There's about 7% of the US that fits into one of these categories. So in total, it's 14%. So about 22 million Americans are non-citizens, and about another 22 million Americans are citizens who were naturalized. And then among the non-citizen category, about 60% or so are in the documented category and 40% or so in the undocumented category. When it comes to thinking about the size of the immigrant population in Indiana, it's estimated to be about 1 in 20 who are an immigrant of some type. And among the immigrant population, then about 40% are naturalized and 60% in the non-citizen category. And when you look at the countries that are the country of origin among immigrants in Indiana, the number 1 is Mexico, the number 2 is India, and the number 3 is Myanmar, followed by Philippines. This is data from the Census Bureau's about 2019 or so. So there's quite a, and that hasn't even gotten into the fact that there's a large set of so many languages represented as you go into other categories and stages. Another maybe important demographic characteristic to point to is also huge differences by education status of the immigrant population. So in Indiana, there's about 1/3 of the immigrant population has college or more educational completion, while about another 1/3 has less than high school. So it's a really, it's very hard to talk about this issue given there is so much diversity of situations.
Wonderful. So I think that gives us probably the best overview that we could hope for of just how diverse it is. And again, we often miss the concept of diversity within diverse groups, right? So it's really important that we frame there, and I do appreciate that. It does look like we have some more questions coming in, so I'm going to start fielding over to some of those. But one specific thing that we have noted several times here already is the idea of chilling effects or cooling effects, right? And those are the things that keep groups from approaching some of the services that are valuable to them, right? So Gurinder talked about that with just having the National Guard present, which is a wonderful example of that. We've also, I believe in Dr. Fabi's presentation, talked about the public charge rule, something that even though it didn't go into force, it was still enough to have an effect there. So what are some of the things that we hear and that we see related to cooling effects, chilling effects that prevent them from, maybe showing up to be able to be seen by Dr. Stelzner and some of the other things. What are we hearing? And Dr. Fabi, you're happy to weigh in too, kind of at a national level, and then maybe we can get a little bit of a boots on the ground example too of what we hear when we talk to the immigrant communities.
Sure. So I can speak a little bit to the policy situation and also institutionally. So, I mean, talking about public charge, there's the fear that even using a service would be held against you, even if you were eligible for it. And in the case of public charge, people were afraid that even their citizen children, because again, the children of immigrants who are born in the United States are citizens, children who are citizens in the US were disenrolled from programs because of the fear that that would be held against their parents in the future. And so although the public charge rule didn't go into effect and would only have affected people who are already legally residing, citizen children were disenrolled, parents were disenrolled, undocumented immigrants were afraid to even seek care, not even try to enroll in Medicaid. And there are a number of studies that have shown this across age groups, children, adults, and older adults. And so that's just one policy. There's also been a lot of evidence that increased immigration enforcement has a chilling effect. So setting aside eligibility questions, just the fear among undocumented immigrants that showing up for care in a healthcare setting, first of all, the travel to the setting. Sometimes you have to travel very far to get to a healthcare setting if you live in a rural location, along highways that maybe have checkpoints depending on what state you're in. And so just the fear of having to drive somewhere, of being in an official setting, not knowing whether or not the health center would turn you in for being undocumented, those sorts of things also create fear and that chilling effect. And so that toolkit that I talked about at the very end has resources for institutions looking to develop, sometimes they're referred to as sanctuary clinics, which is a sort of a definition it's not entirely clear what it means, but the idea is that it's welcoming towards immigrants and sort of offers safety. There's tools for institutions and health centers to, you can put up a sign saying, ICE must check in, right? If you are coming to execute some sort of search warrant, this is where you can go and you're not allowed beyond this point. And having those sorts of barriers up in order to increase, a sense of safety for immigrant patients who have that fear. And I'll turn it over to the other panelists who probably have more experience in that realm. But I think that that's a useful resource for people who are looking to do that.
I agree with everything that Dr. Fabi discussed. A couple of things that, that families have actually said to me, if I refer them to Riley subspecialists who may practice at other settings besides the campus setting, that they don't want to drive to those places because they get pulled over more frequently in different areas around Marion County than they might on West 38th Street. And as well, just the act of driving without a license, you're taking that, it's a big risk every time you get into a car, which I can't even imagine, the daily stress that puts on families. And then just the grind of the applications, I think, is so difficult, even for citizen native-born Hoosiers. I've had multiple young mothers just throw up their hands and say, I'd rather struggle without the services than to put up with the stress of, not being able to get through the application. They just give up. So those are just some personal anecdotes.
I can jump in too, Mark, and I'll also respond to a couple of questions that have come in the chat that I've watched. Just as Dr. Stelzner talked about, one strategy that we are really trying to do and has been very successful is, and Dr. Fabi, Rachel talked about this, is those community navigators. We call them natural helpers. Immigrants, refugees, are very giving people. They have a lot of compassion and they want to give back to others who have given to them. And what we've found is that when we provide them just a little bit of training related to how to navigate the healthcare system, how to help somebody fill an application, that has a huge impact. So even smaller organizations, if you are seeing clients who are talking different languages, who are from different cultures, ask them if they want to help you. See if they just want to sit at your front desk. That creates such a welcoming impact. At your front door, have your signage in different languages. Sometimes even languages, I said, are not, if individuals are illiterate, it doesn't matter what language you may have the sign in. Instead, use pictures. Those things make a huge difference in creating a welcoming environment. And Susan asked me not to get into the politics of it, so I'm not going to get into the politics. But right now, I am advocating very heavily for our sheriff to stop honoring ICE detainers, and I'm going to stop at that.
Yeah, I think we could certainly go all day with looking at that chilling and cooling effect, because it's really the pieces that people don't notice or don't see how substantial they are of what keeps us away from things. Even though we can all in our own lives talk about something that maybe we avoid heavily because of barriers that are in place. And it's not that much different, except when you're coming from an immigrant population and you're coming in with existing barriers, and then you have to approach a system that wasn't built for you, coupled with the concept that there might be some political factors that are meant to keep you at a distance as well. That's a lot of hurdles to clear. So I think we can definitely understand that. So I'm going to jump into some of our questions because we're already going to probably get more than we can possibly answer in the time we have. But I do have an interesting economic question to go into. And this is talking in response to Dr. Fabi's presentation, but I feel Kosali might have some things and others might have to add to this as well. Noting specifically the effect that COVID has had in the immigrant population, but more specifically, a lot of the workforces that are fed by new immigrants. They've noticed, I'm paraphrasing the question, but in noticing how we have a lot of jobs that are going unfilled right now, and a lot of people wondering why people aren't working, why they aren't returning to work, it's suggested that maybe we're missing the fact that we have a lot of newer immigrants that weren't eligible for healthcare that are now being removed from the workplace because they're getting sick, they're getting exposed, and it's a big risk to their family. So is there an economic impact specific when we're looking at that COVID population, saying when we knock out a lot of that immigrant workforce, or we expose them to a lot of risk factors by nature of the jobs they often tend to have? How is that impacting our economy?
There's almost a double whammy, because on the one side, the kinds of occupations, the kinds of living conditions, the kinds of situations that immigrant families are in put them at greater exposure to the pandemic. But at the same time, the policies in place mean that they are less able to benefit from the policies that are designed to help people who are affected by the pandemic, right? So if whether it's stimulus, extended unemployment benefits, or stimulus checks, or healthcare coverage, all of those things sort of they work in directions that are both harsher for the immigrant population. So there's one thing I want to note in trying to say, what do we know about the health impacts, is that a question that's hard to answer is immigrant health related, like healthcare use we can get at by surveys, but just what is the underlying health status, because you'll only be able to measure somebody's health in most of the data sources we have if they are seeking care, and if there are differential access or perceived fears of seeking care, you're going to get selection in who is it who's receiving care. So you might end up getting a picture that immigrant health is worse if it's that only the people who've gotten to the most severe form of illness are taking the risk of receiving care, right? And we know also there's been in the past literature about the immigrant advantage in health, that when you look at health status, you find that in surveys that have asked self-reported health status or other ways, or looking at birth certificate data, because there's a birth certificate generated regardless of, status, that there is better health. And that's often to do with the selection of immigration, the act of coming in as if you're coming, there is selection. So it's a whole lot of things that we would like to know, then coming back to COVID, about health status and how health is affected, that we're not going to get to observe because of the way we have data and because of the way access is predicated upon the status.
Yeah, very, very interesting what we're seeing there. And as much as COVID's lifting the veil off of some issues, it's also letting us know which issues we weren't noting that always existed there, and which ones we just never built the right tools to be able to track and absorb the data. Right. Dr. Stelzner, do you have a comment?
I was just going to say, I think the other thing that puts our immigrant families at risk for COVID beyond multi-generational house, people living together and the types of occupations is their cooperative living. I mean, not only do they, live together, but they give each other rides and, take care of each other's children and those sort of things that are very positive experiences put them at more risk of COVID, in a horrible, ironic way. And then the other is just the bit about the immigrant paradox. And again, that makes me sad that we, bring the healthiest and the smartest and the most, amazing of people from countries because they actually have gotten here, but we don't embrace them and we put them in precarious employment along with, native Hoosiers and Americans in work settings that they're completely stressed out. And this gets to the aspect of where are all of our workers going. Everybody on this panel probably has conversations with these precarious workers, and that's a new term to me, but it speaks to me. The difficult situation they're in every day because of their jobs. They don't have any flexibility to be able to bring their children to the doctor, to go to the school conferences, to be able to take a day off of work to get vaccinated. I mean, many of my families, it's not that they're afraid of the vaccine, it's they're afraid of missing work the next day because they can't afford to take a whole day off of work. And the thought of going to the type of work they're doing, feeling badly is overwhelming, or then having to come home and take care of their children after that long day of work, feeling badly. So, just the daily grind that we have put so many families into is really, I think, the source of why people are just saying, I'd rather stay home and have the time with my family, the flexibility to be able to take care of my small children and do the right thing. It's just my an uneducated opinion about it.
And I don't think, Sarah, that you have any opinions to count as uneducated, but I'll let you get away with that this time. So, digging a little further, so we know these are populations that are going to have more risk posed to them related to their health. We're going to have cooling effects that push them away from that. So do you want to talk about healthcare coverage a little bit? And again, I think Dr. Fabi gave us a few of the barriers that happen at the health coverage level of policy, which is still, we're going layers deep when we go into saying, well, we need to make sure that you want to approach healthcare and feel safe doing that to begin with. We need to have it communicated appropriately to you. But for you to have real quality ongoing care, you need to have coverage as well. So I know one big one that was pointed out in the presentation was the 5-year rule, which is even if you are fully lawfully residing as an immigrant, you have to wait 5 years to get things like the Children's Health Insurance Program or Medicaid programming available to you, other than under certain emergency provisions. And that seems like a big gap. And I know we've got, obviously we've got a pediatrician on the panel as well as an economist here. Let's talk about what the risks are of a child, a young child especially, going 5 years without health coverage, and then just what the overarching cost is when an individual is not covered at purely an economic level. So I'm going to start with talking about the health impact of that, and then maybe the economic impact. So Dr. Stelzner, you can definitely lead into what does it mean when a child goes 5 years?
So, you know, kids can get their vaccines at many different places. So, you know, kind of those sort of, that sort of access, and especially because schools are very engaged in getting that done, is not so much of a problem. But the other things that are offered within a medical home, so the screening, the developmental screening, socio-emotional screening, maternal depression, and the ability to link families to needed resources once those screenings have been done, I think is the main thing that those first 5 years, it's critical, or any of the 5 years, you know, of a child's life. Documenting and being able to do early intervention so that when kids enter school, they're not, you know, having so many delays. Being able to connect them with therapies like occupational therapy if they have socio-emotional issues. Being able to surround the family and connect them with community connections like the Immigrant Welcome Center, so that if they're new arrivals, they aren't so alone. And really, medical homes are the place that happens. And if we don't even have access to that, you know, if the families don't have access to that, and that's not even getting into, you know, school age and preteen mental health, which has just been an overwhelming issue from the pandemic, definitely. But I think beyond the pandemic and the uncertainty of, you know, environmental, climate change, political, you know, conflicts, and then just the difficulties that all of our immigrant and refugee families are facing because of the news that they are getting on a daily basis from their home countries. I think it's just really creating a crisis. And so if they don't have access to us and that link to their schools and being able to kind of provide that comprehensive care, it really is very difficult for them to access what they need.
I could perhaps add some things, and I'm very glad we're talking about children, because when we think about categories of who's affected by the immigrant experience, children are highly affected because in the US today, 1 in 4 children have immigrant parents. So even if they themselves were born in the US, the family experience they have is affected by their parents' immigrant status. And so when you look at health insurance coverage, we know that children are among the most insured in the US today generally. After the Affordable Care Act especially, there's a very historically low rate of uninsurance in the US population as a whole. It's about 10% for the under 65 population. But when we look at children, in general, children are only 5% uninsured in the US. But when we look at children by parents' immigration status, there's a big difference. It's almost double the rate of uninsurance for children who themselves are eligible, but because of the chilling effect. So right there, we're starting off, you know, with issues for children's health really being impacted by immigration and policy towards it. And then to think about what are missed opportunities early on for screenings. We know that catching health conditions, but also behavioral health conditions and learning conditions early on just are so important for thinking about how productive a member is in society, in terms of also think of all the taxes that are paid. So it's, again, this spillover impact of not being able to make people as productive as they can be for society if we don't address needs very early on. That's I think, an important issue here.
I'm just going to piggyback on that, Mark. This is not related to healthcare insurance policy at all, but something that Dr. Stelzner and Dr. Simon have both talked about is mental health. And as some of you know, some others don't, I'm a sick myself. So recently in Indianapolis at the FedEx facility, there was a shooting that occurred, and half of the victims who were impacted by the shooting were sick community members. And we've been holding some listening sessions with these community members to understand their needs. And what we're learning is pretty similar to what we have also heard from our immigrant neighbors, community members from Mexico, from Haiti, is that their children, when they are in the school systems, face bullying because of the language that they speak or don't speak, English as such, or the food that they may be bringing, etc. So imagine the impact of that on the child development. Children start missing school. Families don't want to send children to school. Schools also don't universally, school systems, universally in central Indiana have interpreters who are available to help the families advocate for themselves. So the impact of one policy that's related to schools not having linguistically and culturally appropriate resources to address the needs of the diverse student bodies that we have has a huge impact. So I just wanted to bring that to attention also.
All right, wonderful. And I know we did have a comment in the chat specifically talking about that the schools do take on a lot of the burden as they're trying to provide an appropriate education that also comes with being a healthcare provider, sometimes a de facto healthcare provider for whatever they can do for those kids. And that is a cost that gets shared out as well. So I'm going to ask one selfish question, because this is not on anybody's list coming in other than mine, but it's something we often miss too, and this might be a great one for you, Gurinder, is when we talk about health coverage, and we talk about this with a lot of different groups in my work, but specific with the new immigrants that are arriving. How high on the list of needs for new immigrants is getting healthcare coverage? Is it on that list at all, or is it something that we need to present to them?
Yeah. Excellent question, Mark. And I just want to inform our community members who are here today, just learning in this panel. Recently, I had the opportunity to tour Camp Atterbury, and there are a lot of differences that our Afghan brothers and sisters who are arriving with so much trauma in their heart and bodies that are different from other refugees who arrive in our country. Number one, and Dr. Fabi talked about this, they came, majority of them, with nothing except the clothes on their backs. And they were fleeing a country where they just were not safe. So the usual refugee or asylee process is that someone seeks this status, they are vetted for this process, they go into a waiting process where they go through testing, etc. And then by the time they come to the US, they're assigned to a resettlement agency, which we are not. Immigrant Welcome Center is not a resettlement agency. The two agencies in Indianapolis, Central Indiana, are Catholic Charities and Exodus, and we work very closely with them. By the time a regular refugee, and I'm using this terminology very loosely, they are assigned to a resettlement agency. So they have someone who receives them at the airport, has housing for them, and they receive those services related to healthcare connections and other social service connections for about 8 to 9 months, as Dr. Fabi said. Our Afghan brothers and sisters are not going to receive those services for that long. They're only going to receive it for 3 months. Huge difference. Can you imagine that you have language issues, you have mental trauma, and you're only going to have access to the connections for 3 months? Huge, huge barrier. What we've also learned is that while a lot of them are getting their healthcare screenings and their vaccines at the 8 different bases that they are at right now, that's it. You know, the bases are able to only provide acute care to them. Anyone who needs chronic care is being sent out to the hospital systems. Riley here locally has received quite a few children, and so language access is coming up. So healthcare is not even on their radar, because issues such as, you know, where am I going to stay? You know, majority of them, when they leave these bases, they will have an employment authorization documentation, which means that they will be able to apply for a job. But dear friends, they will not have a social security number. Do you know what that means? You can't get access to internet without social security number. So we're getting referrals for individuals who want to learn English, and they are wherever they are in central Indiana, and they are doing it on this. Imagine you're illiterate in the language, you're new in a country, and you're using this to learn English. I'm going to stop there.
No, excellent points, and exactly why I asked that question, because sometimes we overestimate, because an issue is important to us, where it is on the list of others. And when you're really spending a lot of time just trying to survive and meet basic human needs, healthcare coverage goes way down that list, because that's future thinking, and not everybody has that luxury. So we always need to remember that part of the process. Very difficult to hear, but I appreciate hearing it nonetheless. So we're already getting into close to our final stretch. I said time would fly, and boy has it. But one thing I want to make sure that we return back to is looking at at-risk populations within the immigrant community. So we've had several questions come in talking about older adults, people with disabilities, people living in rural areas. Does anybody have something they can share about the research or what's known or seen about when you add that additional level of barrier, whether you have a personal story on that or something else? But if we're looking at older adults, folks with disabilities, folks with pre-existing medical conditions, or those that are living just more disconnected from some of the services we have, like the great work going on at Eskenazi.
I'll just speak to children with disabilities. The large majority of my patients can apply for children with special healthcare needs, which again is a process, but you know, we've gotten good at helping families through it. And once they have that, it does allow them to access specialty services. They have to have a diagnosis that is included in the covered diagnoses, but that is a huge help. Interestingly enough, if you're here with a visa, you can't apply for that. So that's, I find that most of my kids aren't in that category, but I don't have the numbers. And there are also, you know, about Special Kids Family Voices in source, really great family leaders who can provide other resources for families who have kids with special needs. Most of my families are Spanish speaking, so that is a language that is provided in terms of the family leaders who are bilingual in Spanish. But I think we really need to do, as Gurinder said, our immigrant and refugee families want to help their other, people from their home countries. So to be able to train and recruit and have family leaders to be able to provide that support would be amazing. And I hope that's something that these organizations will do as well.
Great. We do have a question specific to language barriers as well. And really looking at, for a lot of, especially some of the small nonprofits and some of the rural ones where resources are limited, any thoughts on what a small organization, I'll leave those to the group for anybody, but what can a small organization do that has just limited resources to build their competency, to build what they have as far as language translation services? Are there ways they can do that and meet the needs of a population that isn't going to be costly or something that their organization just can't do?
I will say that the Centers for Disease Control and Prevention, especially during the time of COVID, has very intentionally created, I believe this warehouse is located at the University of Minnesota, but check me on that, Mark. That has lots of resources that are available in different languages that are accessible without any cost. Also, you know, having cultural competency amongst your team members, offering them the opportunities to learn about other cultures, that in itself creates a welcoming organization. If I know that translation services are expensive, I understand that, but I think that if you are able to create that welcoming environment, immigrant and refugee neighbors understand that they will receive the help in a manner that that they can accept. I think that I will stop at that because I'm sure my other colleagues have other points. And there's a question by Carol in the chat in the Q&A, and I'll respond to that, Mark, if you want me to.
All right. Yeah, Gurinder, if you want to respond, it's asking about what is being done, what might be in progress to extend the resettlement services.
Yeah, so I think that the issue here, Carol, is that as I explained, and Dr. Fabi explained too, that the US government as such is making an investment upfront, meaning those individuals are here on the US soil and they are staying in these bases for quite some time, where they're getting their food and their healthcare needs met to the extent that they're being met. So because there's 15,000 of these individuals in our country, or maybe the number has increased, 6,000 or so of them are here in at Camp Atterbury. The government itself has limited resources to help them, and we have never as a nation experienced this level of resettlement in such a short period of time. So that's what is also taking long, is making the connections for these individuals to be matched with resettlement agencies who have the ability to accept them. Initially, we were hearing, this is August, so just to give you a timeline when these individuals first arrived, we were hearing that the individuals will start getting matched to the resettlement agencies as early as September, and we're in October, and the process is really, really slow. So yes, when they get into the communities, they have only 3 months, but at least they have that. And then I think there was another question, Mark, about what can someone do to volunteer? Colleagues, please go to the website for Exodus and for Catholic Charities. There are opportunities there for volunteering, for making donations. Also, the Camp Atterbury site itself may have donation opportunities itself. They are accepting donations of warm clothes, unused warm clothes, because winter is coming, and shoes, etc. So there are many donation drives going on. They're very specific though about what they accept. So there are many opportunities as such. So I hope that answers your question. I don't think that there is much that we can do at this time. Dr. Fabi looks like she has something to add. Mark.
I just wanted to add just briefly on the federal level, with regard to what we're doing for Afghan refugees. initially the reporting was that they weren't even going to be classified as refugees because they hadn't gone through sort of the typical process, the 3-year screening. And it was as a result of significant advocacy by refugees, for refugees, and refugee resettlement agencies that got them classified as refugees and got them access to the services that more traditional refugees get. So that is the power of advocacy, and also kind of damning of the government that initially they weren't going to offer that.
And another point that I do want to make, it's a silver lining, for lack of a better word, is that some of these individuals may stay in the visa status, and I'm not going to go into the details of the visa status, for a period of 2 years, just because of the vetting process, et cetera, et cetera. FSSA has said that during that 2-year process, I'm talking about the state of Indiana, they will be able to sign up for Medicaid. That is a big deal. It's important that, because then they will have access to services. What we've also learned is that about 500 of the individuals that arrived are going to settle in central Indiana and surrounding areas, South Bend, Fort Wayne, Bloomington, etc. But that process is going to take some time. And not all 500 of these will come from Camp Atterbury. They may come from different areas. So something for you to know. Tracy, I do not know the answer to your question. I'm sorry. She's asking about state employee drive to collect specific items. I'm sorry, I don't know the answer.
Yeah, I think that might be more of a statement of how to potentially get that through. But we are getting to our last few minutes here. So, wow, gone super fast. I feel like we're only about halfway through everything we could be. I do want to circle back around though, because one thing we do before we wrap up, this event is always about empowering our audience to act and be involved. So if it's possible, in our last few minutes, I think Gurinder actually already got us started on this, but if we could go through and talk about, maybe if there's one, make this the magic wand moment, right? If there's one policy that could change today, what would you want that to be? And if there's one thing you want our audience members to leave this with, something that they could do, something they could act upon, what would that be? So we'll start with Dr. Fabi on that. It's just, okay, so what's one policy magic wand we could change, and then what's something that you would like the audience to feel empowered to do after today?
Yeah, I mean, the magic wand for me here in the state of New York for myself would be for New York to adopt a universal healthcare law, which is currently under consideration, that eliminates any immigration status requirement for state-funded healthcare. And so, magic wand, if I could do that across the country, that would be great. Knowing that that's not immediately practical, I think my suggestion to the audience would be to, I'll put the link in the chat to that state Medicaid policy suggestion box regarding prenatal care and also access to dialysis, because those are concrete steps that people can take today by clicking that link and making that suggestion to your state Medicaid agency. Wonderful.
And Dr. Stelzner, what's on your wish list if we could just get it done today?
I agree completely with the suggestions that Dr. Fabi made. I'm going to do that today and send it to everybody I know. But I also, some of the work that you and I have been doing with the comprehensive services through the school system, I think if we could, use that money effectively that's being drawn down from the federal government and really be strategic and work together to figure out how to sustain those efforts to give that those comprehensive services to the schools. I feel like that would alleviate so much stress and toxic stress and provide those positive childhood experiences that would really, really, in the end, instead of fixing broken adults, raise healthy children, to paraphrase Frederick Douglass.
Wonderful. Kosali, what's on your wish list? What do you see making the biggest impact?
Oh, I'm going to say just having evidence on what policies help, and then having that information out there for people to then do with it as they wish, contact their lawmakers or act on it. Just we want to know what are the things that will help the most.
Can't agree more. And if we haven't learned that we need good data tracking through the last couple of years, I don't know when we will. Wonderful. Gurinder, take us home. What's your take-home message for the audience?
My take-home message is that some of the funding that is coming to the state and the city for the American Relief Act be put towards what is meant for, is to create language access to make services more accessible to individuals. That would be my magic wand.
Wonderful, wonderful. Well, I wish we had another hour or 20 to go into everything. We've stirred up quite a lot of wonderful stuff. And for those asking, yeah, recording is going to be available for this. So if there's things you missed that you need to go back and rewind and catch again, we'll have that posted shortly after everything is done today. But I do want to thank Dr. Fabi and our panelists, Dr. Stelzner, Dr. Simon, and Gurinder for joining us today. Such great women doing such great work. Couldn't be more happy about that. And I am going to note that we're going to be, remember, CEUs are available for this event. So there's going to be, coming up in the chat, there's going to be a link for that. So anybody that wants those, please complete the survey, even if you don't need CEUs. But if you do want it, complete that. IU, School of Social Work, again, sponsoring those, will spit out a survey for you. And then give you the certificate at the end. Always a good thing to support our professionals for getting involved. I'm also going to share on my screen here so we can say goodbye to our panelists as I share over to our screen one last time. But to note all the things that we're doing with covering kids and families and ways that everybody can be involved. So you'll see we have a texting feature where you can text us at 21,000, the word policy, and you'll get updates throughout the year. We do ask anybody who's interested in continuing this conversation, look at joining our policy committee. That's a group that I'm fortunate enough to help lead, along with all of our wonderful providers and policymakers that are part of that group. And my information on that slide as well. It's very much my passion to do whatever I can to help train and support people to get involved in policy, feel active and passionate about it as I do. That's not something that I just say, it's something that really is important to me. So I'll feel bad if people don't contact me after this about more steps of what to do and how to get involved. Nothing's more fun for me than walking somebody up the State House steps for the first time and getting to meet their legislator, because that's where it can all start and there's so much that we can do. It might be more of a virtual meeting this time, but that's okay. But get involved, check us out online on our website, ckfindiana.org, and we'll have you all kinds of steps and ways to get you involved. So one last round of thanks to our wonderful panel and to Dr. Fabi for presenting that keynote. And of course, for our attendees for being a part of this event and giving such great questions. So hopefully we'll see you all again next year, and we'll be in touch before then, I'm sure. Thank you.